Yes, so I'll talk about the intracranial applications of intraop CT, and I've been using that for 20 years, starting with stationary MRIs, and recently, in 2013, when the BodyTom came available, we used that. The whole point is, like spine, that you want to know where you are whilst you do a procedure, and the BodyTom or any intraop CT with a wide bore allows you to do that. And the philosophy is you want error reduction. You want to know when you do something that you're in the right spot, that you have implanted the right electrode, that you've resected the complete tumor, etc. And you can do this with a wide bore, even with the stereotactic frame, in this case the fiducial's on, but you can have the stereotactic frame, the aiming bow on, whilst the electrode is in place, or the biopsy cannula, and take a quick scan. And then you look at it either directly, or what we mostly do is fuse it back to the planning MRI and see where exactly you are. The difference between MRI, of course, which is what we all aim for in intraop MRI, and CT is MRI gives you beautiful anatomic resolution and contrast. But if it comes to exact precision, we have a problem because we have a nonlinear distortion of the image, means that it's more distorted, as you can see from these magnetic field lines, in the periphery than in the center, which means if you're operating in the center of the brain, implanting a deep brain stimulator, it's probably not relevant. But your fiducials are in the periphery. So if they are slightly distorted, then you don't get a complete orthogonal image. And what really happens is in this picture, you can see that the distortion is not linear, not evenly distributed. It is at the edges of the field of vision. And you can see on the right, the heat map. That's exactly where your fiducials are. Or if you have a very superficial structure or lesion you want to attack, their MR distortion can actually be quite relevant. And I'll show you an example on the next slide, where we actually, this was actually for radiosurgery planning, we took the same field of view, segmented the volume, and then without transforming or fusing the MR to the CT, just put them on the different scans. And you can see on the right on the MR, you're clearly within the parenchyma, whereas actually on the CT scan, which is the precise orthogonal image, you are already in the bone, which makes a difference if we are aiming at peripheral targets. So I'm starting with tumors now, and of course the thing you want to avoid is not taking out the whole tumor, have control during the procedure. So in other words, using a famous phrase, you want to avoid the peek and shriek surgery, like in this case, which was done without MRI, intraop CT. You got a little bit of a peripheral resection. The mass effect is actually the same, and you actually cause some hemorrhage. That is exactly what you don't want. So we use this for all tumor resections, and this is a large suprainsular low-grade glioma. And what you can see is this is during the surgery, open head. This is about 50% of the tumor was resected. This is actually the whole tumor. We wanted to define where exactly were we in terms of the medial border. And what we do is either put little titanium markers or paramagnetic markers in and do a scan, which shows us exactly where we are, refuse it back to the MRI scan, and then define our resection borders with that, which is quite nice. And that actually led to a much better resection control than just using navigation, where after opening the dura, because of the brain schist, you can very easily get lost. So that's about resection. I think it's very intuitive and straightforward. Of course, an intraop MRI would be even better, but this is a very good solution. You can always fuse it back to the MRI scan. We routinely, as we've heard before already, use this for biopsies, not only to look whether we have hemorrhages, but particularly we do a lot of deep-seated brainstem lesions, like this very interesting case, which turned out to be a morbus Lee, where we biopsied, and we always, to avoid discussions with our friends in neuropathology, whether we really hit the lesion or not, place a small titanium marker, which is MR compatible as well, at the end of the surgery. So whilst the slides are red and we do the intraop CT, if there's a question whether we're in the lesion or not, we can answer that right away. And that actually leads to a significant increase in diagnostic yield, which in our series, which is more than 5,000 now, is about 97% from frame-based stereotactic biopsies. And it's particularly good if you have very delicate, very small lesions. This turned out to be a lesion, actually a tumor of the infundibulum, which actually was a pilocytic astrocytoma. And again, on the CT scan, you see our marker is placed in the lesion. So we also use this for catheter implantations, and we just published this 2 weeks ago. This is a series of CT scan fused to the MRI scan where we actually treat trapped temporal horns by fenestrating them with a Rickham catheter and additional perforations into the prepontine cistern, which allows you then very nicely to prove that you are where you want to be. This is a bit of a more maybe esoteric application, but a very nice one which shows the beauty of the intraop image during a procedure to show where you actually were and whether you achieved your goal. This is an adenoviral trial in glioblastoma. You can see on the bottom left the glioblastoma, and the idea was to biopsy the tumor, get a definitive diagnosis plus a molecular fingerprint, and then deposit adenoviruses for gene therapy in the infiltrating rim, the periphery of the tumor. We developed this particular sonde with a side outlet, which allows us then to spherically distribute things. And you can see on the bottom right, the titanium marker in the center of the lesion. This is the biopsy trajectory. And the different little air deposits. This is in the periphery where we spherically deposited the adenoviral vector for the gene therapy. So this is a beautiful way to document the volumetric deposition of your compound or drug. And this is just another example of a brainstem tumor where you can always show your phantom precision in stereotactic planning and scans, but adding a titanium marker at the calculated target position for your biopsy and then fusing it back and fusing your calculated trajectory with the intraop CT shows how good and how precise you really are. Another tumor application, but also an epilepsy application, so this leads to the next topic almost, is verification of an interstitial stereotactic laser fiber implanted for then an MRI-guided laser ablation. So we do this all with intraop CT, and the beauty of the laser fiber is, using the Visualase system, is it has a saline cooling catheter around the laser fiber, and that's filled with air, and you can see the air dot beautifully, and it tells you exactly where your laser fiber is. We then have to take the patient to the interventional MRI scanner. So once we've done the stereotactic implantation, we always do an intraop CT before we take the patient to the MRI to ablate and make sure that our fiber is exactly in the right calculated target, which is even more important if you go down to the bottom right, where you can see 2 dots, which was a very large radionecrosis, and where we had to implant multiple fibers to cover the volume adequately. That brings us to the next topic, epilepsy surgery. So again, almost like tumors, resection control, in this case, not of a tumor, but resection control of an epileptic focus or of a disconnection. You can see these are actually both children. One is a functional hemispherectomy, and the other one is a posterior disconnection. And again, what we do is we scan, we look at the volume, refuse back to the MRI scan, but also put a metallic string in there in these cases where we had posterior disconnections to make sure that we really disconnected up to the midline to achieve maximum efficacy. And you can see on the scan very nicely that that's exactly where our markers are. And then, of course, you can also use it for the bottom on the right if you implant grids or strips, and then refuse. Actually, we now use the intraop CT to refuse back to the MRI scan and then do the nonlinear transformation of the grid models on the MRI surface. Absolutely critical is this for stereo EEG implantations, and which we do very frequently. This is a classical implantation schedule with multiple lateral fibers, orbital not fibers, sorry, electrodes, and 2 hippocampal depth electrodes. And you can see on the intraop CT scan exactly where your electrodes are, and also actually see each and every contact, and then refuse that back to the MRI and make sure where you record from, besides the fact that you can rule out, particularly for insular implantations, any potential hemorrhages. And this becomes super critical if you go to very eloquent areas. This is a patient actually who had a small FCD in the supplementary motor area, and you can see we've actually sort of encircled the MRI suspicious area with depth electrode. And then once you have that and really characterized the focus, you can then, through one of those electrodes, we implanted a laser fiber through one of the anchoring bolts and did a ablation of the lesion. Very, very close to highly eloquent cortex, as you can see, but this can be safely done if you have precise localization control of your laser fiber by CT. The other most common application for epilepsy is basically we do amygdala hippocampectomies now almost exclusively as interstitial laser ablations, and there you have to be sure that you cover the medial parts, but you don't start to burn the tentorium to avoid cranial nerve deficits. And for that purpose, you need to show on your scan that your fiber is exactly where you want it to be. And what you can see on the CT panel on the left is you see in red the calculated trajectory, and you see in dark the small air artifact from the laser fiber, and you can see they're almost completely coincident. So sometimes, to make life easier when you have to do either an open resection or in this case actually a selective amygdala hippocampectomy, we put the depth electrodes very close to the brainstem and the tentorium, and you can leave them in basically as a marker. So you know when you see your electrode under the microscope, the next thing you'll see is the tentorial edge, which is very helpful. So that brings us to the next topic. This is still epilepsy, but is DBS. And this is very critical, where actually I would never do this without intraop CT. This is an anterior nucleus of thalamus depth electrode implantation for epilepsy treatment. And as you know, the original trial, the Santé trial, because you have to use a transventricular access, show that about 10% of the electrodes, because they are not that rigid, deviate from the target, which is excessively small due to going through the ependyma twice. And that is critical because if you're too deep, you will hit the mammillothalamic tract and the patient will have significant side effects. And if you're too lateral or too medial, you will not have a good effect on the epilepsy. So here it is actually critical that you can prove before you leave the OR and fix the electrode that you are in the right position. The same, of course, pertains for classic movement disorder surgery. This is a classical subthalamic nucleus DBS electrode, and you can verify the electrode position excellently. With the intraop CT, we always fuse it back to the MR and create what's shown on the next image, which are, these are so-called, we name them hybrid CTs. What you actually can do, this is on the stealth, is you can weigh the images, the CT 50% and 50% MRI. So you get the best of both worlds. You see the anatomy, you can actually see the SN on the MRI, but you can see the bone, and most importantly, you can see the tip of the depth electrode on the 50% CT image. And if you want to, you can also fuse it with the Schaltenbrand Atlas. So you can make absolutely sure that your electrode is in the right and in the calculated position. We've used that to do actually a little study, which is on the next one, where we, at 62 patients, we did both intraop CT scan and targeting with MRI planning and also microelectrode recordings. And as you know, there's a vital debate whether you need microelectrode recordings or can just do it imaging based. The interesting thing is, even if you place the electrodes precisely anatomically, prove that with an intra-op CT scan, which we did in each and every one of these patients, you can see the tiny red bar, which is only 6 patients, but that's almost 10%. We still did not take the correct anatomical CT-guided approach with verification because physiologically we got a better result from another trajectory based on the microelectrode recordings. So having that's actually the best of both worlds. Even more so if you treat more exotic movement disorders, we have a lot of MS patients or cerebellar outflow tremors where we actually don't target a nucleus but the dentorubrothalamic tract, which you can identify with DTI and then superimpose it on the CT scan. And you can see in this case that, for example, the right electrode is suboptimally placed in relationship to this tract and can be revised intraoperatively if you have a precise CT scan. And finally, this is for psychiatric neurosurgery. We, as you might know, are the OCD FDA reference center. So we see a lot of OCD patients which either get treated with striatal depth DBS, and, covering the shell of the nucleus accumbens and the stria terminalis, or with an anterior capsulotomy, which we actually do with interstitial laser now. And again, you can see that your DBS electrodes, or in this case, the laser fibers on the right upper panel, are exactly where you calculated them to be with a superimposed trajectory. Finally, the last topic is we use this for treatment of craniopharyngiomas or other cystic or predominantly cystic diseases. This is a large, partially calcified craniopharyngioma. And we have developed this technique to stent those with RICM catheters with additional perforations, calculated along a stereotactic trajectory, and drain the cysts into the ventricle. You want to achieve this and want to make sure at the end of surgery that you've done so. And as you can see, the catheter is going through the ventricle into the cyst. There was actually, if you see on the lateral X-ray, there was also a cystic component in the posterior fossa, all connected. All these compartments are connected, and to make sure that this is the case, we injected some contrast and did an intraoperative CT ventriculogram, proving that we've achieved our goal. Others have done this as well. This is a paper of neurosurgery, and you can even do a bidirectional drainage of a craniopharyngioma cyst into the ventricle and also into the prepontine cistern if you have intraop CT and can safely place this catheter. And this is the final example. This is a obviously partially resected craniopharyngioma, as you can see on the upper left, which recurred with gigantic cysts, including one in the middle cerebral fossa going down into the cerebellopontine angle. The child was very symptomatic. And we were able, with one trajectory, to drain each cystic compartment into the lateral ventricle. And you can see the catheter placement on the lower right and the rapid reduction of the cyst by just draining it into the ventricle. And this is what you don't want to do. This is a patient that came from the outside, idiopathic intracranial hypertension. A shunt was placed. The shunt actually worked. As you can see, you can drain CSF also from the suprasellar cistern, but the patient had a classic postoperative bitemporal defect. And as you can see on the MRI scan on the right, the trajectory of the shunt, which is way, way too long, went straight through the chiasm. So if you use intraop CT, this should not happen. This is just another case showing you the technique of trapping, of a trapped ventricle drained into the prepontine cistern. And you can, in this case, that's why I'm showing it, we also did an intraop CT angio, which you can do with the BodyTom, to show that we didn't cause any vascular compromise either. And finally, I do a lot of colloid cyst endoscopic resections where, again, you can use the intraop CT, and I use even the stereotactic endoscopic approach and prove, particularly if you have a hyperdense colloid cyst, that you've completely removed the cyst at the end of surgery. So there's a summary. So we, I think we're one of the first BodyTom users. So from 2013 until January 2020, we've done 1,008 intraop CT cases. You see our indications are predominantly tumor, epilepsy, functional, and CT-guided stereotactic biopsies. And I think we would not be able to ever go back to do this without intraop CT. It is very versatile. We looked at our morbidity figures, which have been low before. Our hemorrhage rates, our misplaced electrodes, etc., are significantly better since 2013. I'm open for questions.
Okay, there's a question. What about the use of ICT in brain surgery according to different patient positioning? For example, park bench, prone, or semi-sitting?
Yeah. Semi-sitting is a little bit of a problem because you're limited by the bore. I mean, that really depends on how much sitting, what angle. Park bench is not a problem at all. Even prone, posterior fossa tumors, not a problem at all, because you can use your regular OR table, the scanner slides just over.
How many CTAs are usually needed in OR in general?
CTAs rarely, because we actually did quite a lot to take that back when we started to do SEEGs and stereotactic implantations of the insula. Nowadays, our 3T MRIs with proper contrast administration are so good, you can segment out the vascular structures, arterial and venous, so well from that a CTA is not really needed anymore. So we do this only like this case I showed, where we were very close to the PCOM in those particular indications.